complication, which is a periprosthetic fracture, with more number of hip replacements being done, whether it is a total hip or a bipolar, we are going to see an increase in the periprosthetic complications. This can be either post-op due to low energy falls or many times intraoperative, which may not be recognized at the time of surgery. A number of issues make these fractures a challenge to treat. You have the femoral component of the proximal fragment. Most of these have poor quality bone, making getting a good fixation difficult to achieve. There's high stress adjacent to the tip of the implants, which can make failure of your implants possible. The stem may be loose, may be latent infection, and as I said, majority are elderly patients who have a lot of other medical comorbidities, and also they need to be mobilized quickly out of bed. The first thing that strikes you when you come across a periprosthetic fracture is this a fracture problem or is this an arthroplasty problem? And the decision is basically based on whether your prosthesis is stable or loose. So if your prosthesis is stable and bone quality is good, you have to treat it like you treat a femoral fracture with the problems that I've already enumerated. But if the stem is loose, then you need to go in for a revision of the stem. Finding out whether the prosthesis is loose can at times be difficult. You need to take a detailed clinical history regarding symptoms that the patient may have preoperatively before the fall, a clinical examination. Conventional x-rays will most of the time, if it's an obviously loose stem, tell you that. But sometimes CT scan, MRIs may be needed to make out any subtle loosening. But despite all this imaging that you may do, at times what you think is stable will surprise you on the table. So about 20% of the times what you thought was a stable stem may be loose on table, so have a backup plan ready. An infection workup is important to rule out any underlying infection. The Vancouver classification was standard, divides on base of the site of the fracture, the stability and the quality of the bone. It was ABC before, and now we have this AO-led unified classification system, which not only takes the Vancouver classification, but it also tells you which joint. So here in the hip it is 4 Roman and the femur 3, and then A to F based on the Vancouver type. But we are going to more look at some practical tips on how to treat these fractures. So starting with the type A Vancouver, which is the proximal femur affect either the lesser or the greater trochanter, and unless they are significantly displaced, this can be treated conservatively with just manage them with pain relief and restrict their walking. The type B fractures are the one which create the most controversies. And these are further divided into type B1, B2, B3 based on whether the stem is loose and the quality of the bone surrounding it. So the type B1 fractures is where the prosthesis is stable, you have a good quality bone, and now you want to retain the stem and go ahead and fix the fracture, preferably using biological fixation so that you minimize your surgical trauma and have a mechanically strong construct that can allow early mobilization. The principles of fixation in B1 fractures are similar to what you use in trauma. So your reduction will be a direct open reduction if there's a simple fracture type. If you have a comminuted fracture, yes, you want a bridging construct by MIPO techniques. The stability again should decide by the type of fracture you're dealing. So many a times when you have a simple fracture pattern, there is always this temptation, let me go get an interfrac screw, get absolute stability. And if the bone quality is good, yes, you will get away with it. But in majority of these patients, the bone is osteoporotic. Trying to achieve absolute stability and rigid fixation is difficult. There will be under compression, the medial cortex will collapse. That leads to micromotion at that fracture site, stress concentration, and early implant failure. So now in B1 fractures, the relative stability fixation is the norm. You can optimize this relative stability by getting an accurate reduction, especially if you have a simple fracture type. Try and achieve some compression across the fracture. But when you use an implant, use long plates. And use a plate that will span the femur, and it is called substituting your lateral cortex of the femur with the plate. The fixation should be spaced out. The screws should not be too many. When using, try and use screws in both the fragments because they give better fixation than when using cables or wires. So what you're looking at is a compressed length stable construct that will give you a good result. Here are the two cases that we used using this principle. When fixing B1 fractures, it is very important that you get the integrity of your medial column correct. That is vital. In fractures where there may be a comminution, especially at the stem, tip of the stem, or there is a free calca fragment, just fixing this with a single lateral plate can be difficult because they are prone to varus failure and early implant failure will occur. In such fractures, should you treat by fixation, you will have to augment your lateral plate using a medial cortical strut graft. If not, the other option would be to a revision so that your long intramedullary stem acts as a buttress. Coming to the type B2 fractures, this is where the stem is loose, but your surrounding bone is good enough for a normal straightforward revision. So the principles of revision surgery come in. Try and maintain your bone stock. Use a stem that is long enough so that you bypass the fracture site by at least 5 centimeters to get fixation in a distal fragment. Use any additional augment fixation if necessary to give you good results. Type B3, not only is the prosthesis loose, but the bone quality is also very poor. And straightforward revisions are at times difficult. You may have to go in for a proximal femoral replacement kind of a stem or a tumor prosthesis. It is always a good idea, whatever stem you use, to wrap whatever is left of the proximal femur around the stem, because with time you'll be surprised how well that bone can reform. The type C3 fracture now is where your fracture is well distal to the tip of the stem. So there is no issue about the stability of the stem. These fractures should be treated on merit. If they are comminuted, a dual fixation should be done. What is more important is that make sure you overlap the distal part of the stem with your plate so that you now don't create a stress riser between the two. And this will ensure good results. A type D fracture now is something that I call a type C made more difficult with the presence of a total knee below. Again, if both your implants are well fixed, you need to fix the fracture. The principles remain the same. Long fixation, spaced out screws, dual fixation in probably most of these patients of type D, which ensures a good result. These fractures are difficult to treat with a high rate of complications, so you need to make your patients aware of this before you embark on treatment. So to take home, periprosthetic fractures are now on the rise. It is the stability of your fracture which will decide how you go ahead to treat these patients. If the stem is stable, fix the fracture. If it is loose, revise it. Whatever you do, make sure you can mobilize the patient early. Thank you.
Thank you, Sunil.